Started. Welcome everybody to this afternoon session of our first webinar in the home and community-based services level of care training. I'm going to give the microphone over to Colette Pollen from the DOH team, and she's going to give us a little introduction.
Yes, good afternoon, everyone. This is Colette Pollen from the Department of Health. First, thank you very much for joining this webinar today. Our goal is to provide you with some helpful information and techniques to complete the home and community-based service level of care, the tool that you've been using to assess children and youth to become eligible for these services. You know, we've been now a little over a year in the new waiver, so we thought this was an excellent time to regroup, see what folks are doing, and provide the information and assistance. Also, it'd be a good time for you all to share your experiences, ask a lot of questions, maybe share some examples or problems you've been encountering, so that you can get assistance or, help with processing those issues. So I want to also thank Chafin Hall and Susie and Josh for doing this three-part webinar for us this week. Our goal is that if you signed up this afternoon, that you could do the afternoon session all 3 days, but if you can't, I just want to grant people permission to do the morning session if there's a conflict that you have. This three-part series was made with the intent that the person goes through all 3 sessions together. Dr. Button will share with you that there's a little homework assignment for tomorrow, and then on Wednesday is really the best time to present, case scenarios, questions you may have, thoughts, suggestions, even tools that might be helpful that we can create for you and your and the staff at CYES. We also will share with you, if you don't know, we have the CANS Institute website, and there's already a lot of different types of tip sheets and 5-10 minute videos that can help you in different topics of the CANS in the HCBS, so it can strengthen your knowledge and skill around the tools. So once again, I just want to make sure that I welcome you all. I appreciate your time. I know everyone's very busy, but I think this will help all of you to move forward. And again, really open to ideas and suggestions, and please share your questions as we go through the presentation. Again, I want to thank Dr. Button and Josh for putting this all together for you.
Thanks, Colette. You're very welcome. I just want to introduce myself and my partner. I'm Susie Button. I'm the director of the CANS New York Training and Technical Assistance Institute, and I'm going to be doing a lot of the talking today, but sharing the support and also jumping in when it's relevant will be my partner, Josh Nellist. Josh, you want to introduce yourself?
Yeah, hi everybody, I'm Josh Nellist. I'm with the Parade Institute.
Thanks, Josh. So let's talk a little bit about what this series of webinars is about. We want to sort of check in with you and make sure that we're moving through these learning objectives. Today, we're going to focus on an overview, a quick review of transformational collaborative outcomes management and communiometrics. Those are those practice and measurement models that you learned about in your certification training. I recognize a lot of familiar faces from those who are on camera, so many of you I know did that training with me in the city about 2 years ago. We're going to just do a quick refresher on that. We're also going to try and talk today about how the HCBS eligibility determination derives from those principles and how they're linked. And we also want to talk about collaborative assessment and a strong understanding of the connection between good collaborative assessment and the outcomes of those determination algorithms. Later on in the series, we're going to talk more specifically about the items, what they mean, what they're measuring, and how to assess for them. And we're going to focus in on those action level ratings, how they can help you not only determine HCBS eligibility, but also focus care coordination. And we're going to spend some time later on in the webinar focusing on those really critical extension modules that are such important pieces of information when you think about HCBS services and what they're for. But today we're really going to focus on these first three objectives. So it'll look like this. We're going to do the first three objectives today. And we're going to ask you to do a little homework tonight. When we sent out our handouts, we sent you a vignette, a one page, maybe one paragraph plus. Read him tonight, his Charles vignette. Please read him before you come on to tomorrow's webinar. As Colette said, we're offering webinar 2 both in the morning and the afternoon. And if any kind of a schedule conflict comes up with the webinar you're registered for, just shoot us an email and we will gladly sign you into the other time frame. On Wednesday, we're going to have a third webinar. That's a Q&A webinar, and that's going to be more powerful the more I know about questions. So you can feel free, and we really encourage you to lob in questions and thoughts today. But we also want you to keep track of examples and challenging rating questions and things that come up as we go through the slides in the next 2 sessions, and send those to us in advance. We'll chat our emails out at the end. And we're going to try and organize webinar 3 to have time to answer questions that have come up in the first 2 webinars, any questions you send to us in advance, and then give a little time just for conversation on that day. So please remember to read that Charles vignette before our next webinar. We're going to take a quick look at him today, but we want to make sure that you have a sense of that story when we get to the care coordination part of the training tomorrow. So let's take a look at our overview, our quick review of TCOM Communimetrics, and then a little bit of a deeper dive into the principles of collaborative assessment. So you probably remember this slide from another time with me, or this concept from your online certification training. This is the practice model that really underpins the use of the CANS New York and even the subset of items that you're using for HCBS determination. And it's TCOM. It stands for Transformational Collaborative Outcomes Management. You know, the idea behind this practice model is one that nobody's going to disagree with, and that is that we get into this business because we want to help people transform their challenges, and we want to particularly help children and youth develop and grow in a healthy, forward way. In order to really be effective in engineering transformational change with the people that we serve, we have to know how to be collaborative. And when we say the word collaborative, we mean a lot more, and we add a lot more specificity to the idea that we listen and respect the priorities of the people we serve. It goes even further than that. We want to really develop a shared vision and a shared understanding of what the needs and strengths are of the young person we're serving. And we want to move forward with that collaborative vision. And that shared vision should certainly start with and prioritize the voice of the consumer and the caregiver, but it also should incorporate all the key stakeholders who touch the life of the child that we're serving. And when we get to outcomes, right, we want to measure things that are relevant to what we do. And what we mean by that is we should use the action levels that we're rating and measuring here to not only drive our decisions around what our care plan goals are, or for you, our care coordination goals are going to be, but also to measure progress toward those goals. So if we start out with a 3 and we make a referral and we get down to a 1, right, that means that's good progress, right? So we want to be thinking about that, but also we're going to talk about how we use those outcomes then to manage our system, right? We're using those when we get to the algorithms, and then we're also going to use those to see if in the aggregate we're changing the needs of complex needs kids in our system. So how does this link to HCBS services? Well, it actually links pretty well. If you think about it, right, on the left-hand side of the slide, you see some of the values that drive service coordination and HCBS services, right? We know that those services are community-based and they're family-driven and youth-guided, and that's because we want to be serving children in the least restrictive environment possible, and we want to be prioritizing, as we well know, when we prioritize the needs that the family and youth identify as their key needs, we tend to do better and make more progress when folks have complex needs. And from an HCBS perspective, when we put eligibility on the table, we want to think about, will these services help this child? And when we think about that, we want to think about, will these services address concerns with day-to-day functioning? So eligibility for HCBS is linked directly to whether needs are interfering with the child's functioning. If you flip all the way over to the right-hand side of the slide, you can see that the TCOM values, right, the practice model values for TCOM overlap significantly with that approach. We're talking about personal, person-centered transformation. We're talking about, right, building consensus on action needed to help kids function, and that goes with that family-driven, youth-guided perspective. And we're also talking about making sure that the whole story of the youth and family, not just the HCBS items, drives our action plan so that our work is really functionally focused and person-centered. And in the middle of all that, we can bring a lot of really wonderful strategies that we all want to bring to our work into the mix, right? We want to learn how to deeply collaborate with the people we serve and be culturally responsive and respectful. We're going to use our action levels to be outcomes-based, and we're going to always think about knowing, learning, and building the strengths in the children that we're serving. And the focus on the action level language can help you build a team while elevating family voice and choice and staying individualized, right? And an awareness of trauma is an ongoing value that we want to bring to this work. So how do we do that when we're doing the work that you're doing specifically, which is looking at that eligibility determination and then the coordination of HCBS services? Well, we have to start with a foundation of deeply collaborative assessment, right? And through collaborative assessment, right, when we're able to build that collaborative relationship, and when we take the time and the care to gather complete, meaningful information before we complete the determination for eligibility, we're going to be certain then that the eligibility matches the story of the child and family. So we want to make sure not only to have those critical, those important conversations with youth and family, but we also want to make sure to go through the records thoroughly. And those should be current records, right? They should include conversations and record review for any involved service providers, educational providers, family members, natural supports, community supports of any kind. And once we've gotten all that information, we have to integrate that into a shared understanding about which needs are present that are impacting functioning in daily living, right? You also have to make sure that when you've collected all that information, your documentation, and importantly, your HCBS ratings are all neatly aligned. When they're misaligned, what happens is the story of the child and family is not reflected in the determination, and consequently, we might not be applying the right dose of service. And we're going to talk a little bit more about dose of service later. So here is a nice metaphor for how we want to think about your role in the context of collaborative assessment, right? Let's think about a baseball game, right? You're kind of like the manager or the umpire in the baseball game, right? Your job is to collect the stats, right? And to use those stats, in this case, the action levels and the information from your assessment process, to make sure that you're driving the game. That's the plan of care. You're choosing strategies, techniques, skills, activities, equipment to make sure that plan of care is focused and related to the stats. but all of the information you're using really comes from your team, right? A good team manager listens to and observes the players on the team and incorporates all of that important information into decision making. And so your team in this case is the child or the youth, your consumer, the caregivers, right? Anyone important in the child's life, service providers, teachers, educators, and all those key natural supports and stakeholders. They're the ones who are going to give you information to help you guide how you rate the stats, and they're going to give you information ongoing and how that plan of care is working moving forward. So in order to use a tool collaboratively and to be person-centered, you have to understand its key characteristics. And what we see when we're reviewing cases that are challenging in terms of, wow, the story of this child doesn't seem to match the outcome of the algorithm for eligibility determination, what we often find is that the miss is somewhere embedded in one of these characteristics. So we're going to spend a little bit of time on them today. So let's go to the first one, which is that items are included because they are relevant to planning. Now, what does that mean for you? Well, remember a few minutes ago, we talked about service dose, right? And I said I was going to talk about that more in a few minutes. What we're starting to learn and what we're really beginning to know is that we actually can provide too little service or too much service to people with high needs. What we're learning is that we really have to find that just enough service level for kids. So items are included in the HCBS eligibility algorithm because they're relevant to the services that tend to prevent placement. We don't want to over-apply those kinds of services, those heightened services, if kids don't need them, and we don't want to under-apply them if kids do. So we want to make sure that we understand the story in order to make a good decision and then make a good plan. So let's take a look at an example. And I'm going to have you take a look at this with me. I'm going to ask you some questions to chat in to everyone in the chat box. So this is Malcolm. He's 2 years old. He has significant medical needs. And during your first conversation with Malcolm's mother, she tells you she's worried about Malcolm's developmental progress because his communication seems delayed. She also mentions that Malcolm had corrective surgery for cleft palate last year, and she says he's finicky about many, many foods. But then you pull the post-surgical follow-up report from the cleft palate correction, and that report reveals that Malcolm's surgeon described his surgical outcome as only partially successful. So let's think about this for a minute. If you only knew that Malcolm's communication was delayed, what would you start thinking about in terms of what items to rate or what services Malcolm might need? What would be some of the things you would be asking yourself or thinking about? Are there developmental delays, right? So that first piece of information is really focused on his development, right? Melissa says that, are the developmental delays. Augusto's saying that too. Mia is saying, what about speech therapy? I'd be thinking in that direction. And then lots of other folks are texting in speech therapy, right? So now move to the next sentence. Now you hear that Malcolm's finicky about foods and that he had surgery correcting a cleft palate. What would you start thinking about now? It's another layer of information for you. How does that change your focus or your sole focus on development and speech development? Okay, so now people are shifting. Doris is saying, now I'm thinking about his nutrition level. Angela is talking about texture for his food. Monique is asking, did he get the proper nutrition? And Augusto is saying, now I'm actually thinking that speech might be because the surgery wasn't successful. Someone else is thinking about oral motor control. And then we get to that last piece, right, that the surgery was only partially successful. And some of the team are already texting in. Rebecca is saying, well, why was it only partially successful? And Robin is saying he might need a swallow study. So you can see that not only would be starting to think about what ratings in the HCBS algorithm we would put together, this little bit of information is so relevant to planning. If we only had one isolated element of it, we wouldn't be able to plan effectively, but each element of it has you asking different questions and wanting to reach out and flesh out the story so that your ratings are right on target and your services are right on target. It's a great conversation, folks. So the next key principle can be really helpful when you're thinking about how to rate and when you're thinking about linking the story of the child and family to the ratings, and when you're thinking about building consensus. And that is that each item uses a rating scale that translates directly into action, right? And you remember this from our previous trainings, right? That 0 on the needs means no evidence of a need and no need for action. Now, please notice that we don't say we absolutely know there's no need there, but we do say right now we don't have evidence of a need, so we don't need to do anything. A 1 on the rating scale is this is a history. Maybe this child had, maybe Malcolm was failure to thrive, but he isn't right now, but we want to keep an eye on it because he's still young and his percentile body weight is still approaching a normal level, right? Or a need that's not interfering with functioning right now, right? This is something we want to watch for or get more information. Like in Malcolm's case, we might want some more evaluations. When we step up into a 2, we think about the need as interfering with functioning, right? And when we think about that HCBS service definition, that's interfering with day-to-day life, healthy growth, development, well-being, we need to do something about it. When we get up to a 3 should be rare. This is a need that is pervasively disabling, preventing child from growing and thriving, or putting the child at risk. Immediate or urgent risk, it's dangerous. And this is where we would need to take immediate intensive action. Now, you don't rate the strengths, but we also want you to always think about strengths in your head when you're getting to know a consumer and a family. And so we sort of flip those ratings. And again, we're thinking about action when we think about strengths. If a strength hasn't been identified, we want to build one. If a strength has been identified but it isn't useful, we want to get it back to being useful. And those 0s and 1s on strengths are those strengths that we don't necessarily need to build. We can actually use them in the plan. Now, this principle is more clearly understood, and we can apply this principle in our work with kids and families and our ratings much more simply when we separate out these 2 ideas of function and action. Right? So sometimes it really helps to nail down an action level if you think about it from this perspective. You can ask yourself on any given need, what is the intensity of the need? And by that we mean, to what degree of this is this need getting in the way of functioning, right? And when we think about HCBS, we think about, right, the services are supposed to support functioning in day-to-day life, right? So if Johnny has no depression symptoms and it's not getting in the way at all, right, and we don't see any evidence of it, that would be a 0. But if Johnny had depression 2 years ago after his mother died and he really started bombing out of school and relationships and misbehaving and needed really significant treatment, but he's doing well now, we might put a 1 on that, right? It's still not actionable, but it's a significant history and we want to keep an eye on it. When we get up to 2s and 3s, this is a need that is definitely interfering with functioning. And what that means really at a 2, right, if Johnny is depressed and he needs ongoing treatment to keep doing well in his life, right, we need to give him a 2. It's interfering with his functioning. And a 3 is if Johnny's depression is preventing him from functioning pervasively across critical life domains and or putting him at some kind of risk. We can also flip over to that action box, right, and say, well, what's the urgency of intervention, right? And what I like to say to myself is, what would I do? Would I do something right away? Or would I do something in the plan? Or would I check on it? Or would I just put it out of my mind, right? So if Johnny doesn't have a history of depression, we're not going to take action and we're not going to do anything about it. If he does, I'm going to check in on him. Are there symptoms coming back up? If he's under stress, I want to really check in with him. If he really needs treatment, we're going to provide treatment. And if he's at risk, we're going to provide restrictive treatment, right? Or immediate intervention. And so these ways of thinking about it can help clear it up for us. And also, incidentally, help us talk to kids and families about it. So let's take a look at another example. And again, we're going to do a little chatting around this one. This is Mandy, right? She's an 11-year-old girl with an extensive medical history. She's enteral feed dependent and can eat by mouth, but she has oral aversion and will only eat foods of certain textures with significant support and coaxing. She also has an elimination disorder that causes her to urinate frequently. She attends school, but her teachers in her one-to-one report that her need to visit the restroom frequently and her anxiety about that are interfering with her ability to focus in the classroom, and they're affecting her grades. So let's think for a minute about functioning. What do we see here in terms of needs that are interfering with Mandy's day-to-day functioning? What do you see? Just go ahead and chat into the box. What are some of the needs that you might rate or start thinking about on the eligibility? Right, so there's an elimination need. Augusto is identifying, and Robin, urinary urgency and anxiety, Melissa says. Rachel says her anxiety, right? So everybody's starting now to chat, and here are two needs that we know we need to look at. The elimination item, right, and the anxiety item. Okay, great. So now we're starting to think about those items we have to focus in on. In order to rate those items, right, we've got to think about how much is it interfering with her functioning. So what do we think? Is it, remember we said we've already ruled out there's evidence of a need, so we're not going to give it a 0. So let's think about this. Is it getting in the way of her functioning in school and her learning? Interfering with school, everybody's chatting in yes. So we already know we're up in that 2 to 3, right? Here, all the yeses are flowing in. Now, let's take a look at action. What would we do? Would we do nothing? Obviously not. Would we keep an eye on it? What do you think? Do you want to do more? No. So someone's saying no, we want to take action, do more. Rachel is texting in, let's do more. Good, yep. Requires action. Augusta says we probably need more information, right? Between a 2 and a 3. So we know already when we're thinking about that action function paradigm, we know already that we're up to a 2. And indeed, right, folks are citing lots of things that they might need to find out. What's going on with her anxiety? We need to know what her grades are, possible catheter there. There needs to be action with anxiety and discussion with the MD about the urinary urgency, right? So we know it's either a 2 or a 3. Good, great discussion, guys. All right, now we're going to move on to the next key characteristic. And I want to say that if you sleep through the whole webinar this morning, just stay awake for the next part, because what we find everywhere we train and everywhere we work with folks is that this is one of the most challenging key characteristics of the tool. And when the story of the child and family doesn't match the rating and the algorithm doesn't match, it's almost 90% of the time that we find that it lies in a misapplication or misunderstanding of this principle. So we're going to spend a little time on this one today. So this characteristic says that rating should describe the child or youth, not the child or youth in services. All right. So what do we mean by this? Well, what we mean is that some services that we provide for the consumer resolve needs, some services improve needs, but some services actually can mask the presence of a need, right? And so when we're rating needs, we have to take into account the services that might be masking that particular need. So I'll give you an example from medicine, right? We know that antibiotics are used for different things, and that antibiotics can have different effects on diagnoses. So if I have a strep throat, or my daughter has a strep throat, and I take her into the doctor and the doctor prescribes an antibiotic, then within 10 days that strep throat should be resolved, right? That strep throat is gone. The antibiotic eliminates the bacteria that's causing the strep. But if someone gives a patient with Lyme's disease antibiotics and doesn't prescribe them for a long enough time, that actually can mask the presence of the Lyme's spirochetes. And indeed, I have a family member for whom that happened, and over a series of years was repeatedly given short courses of antibiotics to the point where the spirochetes were able to embed in the nervous system. So in that particular case, although the antibiotics were getting rid of the symptoms for a short period of time, they were actually masking the presence of that disease. Well, services are like that too, right? That some services can mask the needs in the youth that we're serving. So we're going to take a look at an example now. Here's a youth with severe medication-resistant depression, which pervasively impairs functioning. That youth began receiving ketamine injections 2 years ago. And some of you may know that ketamine injections for depression are a rare intervention, and they're very expensive. So in order to get there, you have to be pretty significantly treatment resistant. Each time the young person receives an injection, his depression and his overall functioning improve. The effect of each shot lasts a few months, after which his more vegetative symptoms of depression resume. In order to keep functioning at home and at school, this young person is required to take additional injections of ketamine every 6 months since they were first prescribed. So let's all just chat in. What would you say the ketamine is doing? Is it resolving this young person's depression, improving it, or masking it? Band-Aid, I hear, masking, 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 masking. Great, so everybody's texting in that this is indeed a masking intervention, right? And the way that we know that is that this young person repeatedly, right, and Augusto is saying masking, but this is complicated. Augusto, do you want to say more? Can you unmute yourself and say a little bit more about what's complicated?
Yeah, my background's behavioral health, and when you were reading this example, I was thinking of Vivitrol injections, which I used to give on an outpatient basis, and the Vivitrol is for substance abuse abstinence, but even the makers of Vivitrol acknowledge that there's a therapy component that has to be an adjunct with the medication, that the meds alone is not going to get the person there. So,
right,
this child is seeing some improvement with ketamine, but, I don't know. This is where the SED is kind of complicated with how people positively react or not to medication.
Yeah, and
we evaluate that.
Yeah, I think it's a really important point, and it points out some of the other things we've been talking about. We're using this example with our understanding of the treatment in isolation, right? But we obviously, if we knew this young person was in our care, we'd want to be thinking about making sure that he's got the services and supports that start to resolve the need, right? Coping skills around depression, right? Some of the more lifestyle changes that can work with severe depression, right? It's a really important point. So, but the idea is, right, notice that we're starting to think, as we should, about planning and about what other information we need, but we're also thinking, okay, we can't do this in isolation because it's simply masking a need, right? So we have to start looking at some more long-term planning as well. It's great. Let's look at another example. And again, I want to encourage you, it's good discussion this afternoon. I want to encourage you to throw out your ideas and raise your hands. So this is another kid with a SED presentation, right? So she's 16, Nicole, and she has diagnoses of ADHD and intermittent explosive disorder and social anxiety. She's been hospitalized twice in the past 2 years for aggression, and she has ongoing significant problems with school attendance. During her last hospitalization, which was about 60 days ago, Nicole was placed on high doses of Intuitive and Vyvanse for the focus and Celexa for the aggression and impulsivity. And she has really been improving in those areas in the 60 days since that admission. However, her school has placed her on home instruction because of her avoidance of school, and she does her work each morning at home instruction. So I want you to think about the masking principle here. What do you see that hasn't been improved, but is really being masked by a change in the child's context? What do you see? What are we not hearing about in terms of the hospitalization? All right, I accidentally moved my chat box out of my school attendance issue, right? Socialization, also the living situation. We don't know anything about it. Again, that's that, let's start thinking about her story. What don't we know? And then Robin's saying, right, she's getting her schoolwork done, but she's not going to school, and nobody seems to have done anything about her social anxiety. And so her attendance at school is, right, not resolved. Her anxiety is still interfering with a key functional area, and we would rate it as such, and we would need to attend to it. Good. You're a bunch of smarties. Very good. Okay. Let's do another example from the SED population. Here's Dolores, and she's 14. She's had some problems with peers, has a history of poor judgment, and a history of running away. When she's living at home, she'll break her curfew and sneak out of home at night to hang out with her friends. But she's been in a locked diagnostic unit in the community for 5 weeks as a result of an explosive incident at home, which resulted in her running away for the 3rd time in 2 months prior to arriving at the locked unit. So let's talk about running away. What do you think? Do we know that we've made a dent in her running away? No one. So Robin's asking, why is she running away? Rebecca's saying, what about family dynamics? Jacqueline is saying, no improvement here. Everybody's texting, no. And Izzy is saying, what's going on in the home, right? Great. So we've locked her in a diagnostic unit. She can't run away. So we haven't seen her runaway behaviors in the 2 months that she's been, in the 5 weeks that she's been in the diagnostic unit. But we most definitely have not, we don't have evidence here that work is being done to address the underlying issues that lead to the running away. And Melissa's saying children who run away will continue to do so unless the underlying issue was resolved. Amanda is saying what's going on inside the home. And Rachel's saying we don't know if she'll stop when she's let out. And so our evaluation of her, right, if she's coming out of services into HCBS, we want to think about the underlying issues that might be contributing to the running away. A, as everybody is saying, what's the living situation? What are the dynamics in the home? What are the supports that she might need there? And B, what about Dolores's impulse control and her judgment and her capacity to tolerate stress? What might we want to put in place there? Great. Right? And someone else is saying poor decision-making might be an issue, caregiver supervision might be an issue. And so we need to look at both what are the child's internal needs that haven't been addressed, and maybe they have, but we just don't know it yet, and what are the living situation needs and supports that we can put in place. So let's just do, because this principle is so important, let's do another example, this time from the medically fragile DD population. This is Bella, and she's 14 years old. She has multiple medical diagnoses and developmental delays. Bella has a tracheostomy and a gastrostomy tube. She's nonverbal and non-ambulatory, and she depends totally upon others for self-care. She attends school. She has a 1-to-1 aide and in-school nursing. And Bella's family reports that they have a really strong system of paraprofessional supports at home, and they're happy with Bella's services at school. They say she's doing very well in the face of her challenges with these important supports. So let's think again about that masking principle. What do we think is are Bella's needs if we pulled her supports away, that's a question we want to ask ourselves. If we pulled her one-to-one aid, her nursing services, if we pulled them away, would she continue to thrive at school? No, right? So another thing, right? So no, first of all, she would not. And then Melissa is actually texting in the answer to my next question, which is, right? The supports might be masking other issues and she couldn't thrive without them, right? So it sounds like she is thriving, Robin says, and absolutely she is, right? But we would want to, certainly as we're deciding upon the ratings, we want to get a lot more information about what's being masked specifically by the presence of supports, right? We know that we want to rate based on that masking principle and not just based on Bella's family's report. Although we're really glad they're happy with the system and we know they're doing well, we want to make sure we don't underrate her if the supports being pulled would lead to a precipitous deterioration in her thriving. And so we want to sort of wrap up this section, the masking principle, by showing you a resource that we have. I think we sent it out to you ahead of time. This is a little flow chart we've developed, and it's a part of a tip sheet on this masking principle that you can use to walk yourself through whether or not an intervention is masking a need, right? So first of all, if a child is not receiving any services when they come into your, onto your desk, then you can decide just based on what's going on, what the needs are, right? Because no services are occurring. That's unlikely. Most of the kids that you're seeing are going to be kids who have some services in place. So you want to go down to, Augusto, I see your hand up. I'll be right with you. You want to go down to the next question, which is ask yourself, if we pulled the intervention, would there be an immediate likelihood of risk or deterioration, placing the youth at risk of adverse events, right? Most specifically with HCBS, at risk of a higher level of care. Immediate, right, we like to think about as within 30 days. If the answer is absolutely, if we pull this service, for example, if we take Dolores out of the locked unit and she's going to run away as soon as she gets home, we're going to put a 3 on that runaway item, right? But the answer is no, we're not done yet. We want to sort of say, okay, we know it's not a 3, but how do we rule out a 2? So then we say, okay, 30 days, the child might be all right. But if we pull this service, would that adverse event, and in our case, it's that higher level of care, be likely to occur in more than 30, but less than 90 days? If the answer to that is yes, then we want to rate it a 2. Important in both of these cases, we want you to document your rationale for justifying the masking principle. Don't just put in the rating, but put in the information that relates to that rating. And Augusto, I wanted to just get back to you.
Yeah, just that last slide with the MedFrats child that had the G-tube and had services in place regarding the idea of masking. What it made me think of was because families seemed like they were very happy with the services they were receiving, and you know, as nurses, we always want to try to maximize independence, and I feel like sometimes you could run into you know, some opposition with the family not wanting to change the status quo, feeling that we're happy with the services, everything is working, why not just leave it alone? Whereas, again, it might be masking a need, but also if we can make the child more independent, why not? And that might be a bit of an issue.
Yeah, it sounds like a tricky balance. I mean, the first step is making sure the child is eligible for the services that they do need or that they are getting, right? And that's where we want to really take that masking principle into effect. But then when we get to the care planning, we're not going to put a service in place that the family doesn't want, but we are going to work to build that consensus, right, about increasing and strengthening autonomy and independence. And that's a really, a very tricky sort of a balance. Really good point.
I would just add to that too, Susie, that's where the idea of the action levels being related to both action and function come in, right? Because sometimes the functional need that exists might not always line up with a need for action, right? Because in some cases, a family might say, we've got this, like we know there's a need, we all acknowledge it's here, but we've got this, we don't need your help in this situation, right? Whereas in other situations, certainly when it comes to medical interventions, they need the interventions, they need the help that the system provides. And so that's where the action levels give us that capability to reach a consensus using action and function and thinking about both.
Wait, nice, Josh. So we just want to remind you, we sent out the tip sheet, right? And Josh texted into the chat box where you can find a downloadable PDF of this tip sheet if you ever need another copy. It's two-sided. It defines the principle. It gives you that flow chart, and then it gives you some examples in application. So let's just do a quick review of this next key characteristic. I think, as Augusto said, you're all nurses. I think these are pieces that are really core in nursing training. And so we're just going to give a quick check-in on this characteristic. And that is that we ask that you take development and culture into account before assigning an action level, right? So in this following example, we're going to talk a little bit about development, but we want you to separate those two questions out. Right? Take the individual consumer's developmental level, not chronological age, into account before you decide about an action level, and always be sure to take culture into account before you decide about an action level. So let's take a look at what that looks like if we're using development first. So this is Roberto. He's 3. He has average intelligence. He likes to throw his body on the floor and kick his mom and scream when she tells him no. He does this about 4 times a week, and mom says she's struggling to help Roberto manage his anger at this time. So the first thing is, right, let's talk a little bit as a group about what's developmentally normal or average in terms of Roberto's behaviors and what feels like it calls for action. So chat in what your thoughts are about those two pieces. So Rachel, exactly right. And Melissa, they're all saying most 2 to 3-year-olds throw tantrums, right? Melissa says temper tantrums are normal, but kicking mom is not. Robin wants to know how long are the tantrums. Jacqueline says it's normal, right? So exactly, right? Most 3-year-olds have these behaviors, right? But how often, how long, and kicking, right, can happen with a 3-year-old, but you have to teach him, right? Augusto says we need more context regarding the tantrums, right? And Rachel says the tantrums are developmentally appropriate for the age, but to what severity, right? 3-year-olds have tantrums, says Monique, but the kicking is the question. So you've all got it, right? We're all floating around with this example and saying, okay, 3-year-olds have tantrums. Let's not freak out. If this was a 16-year-old throwing himself on the floor, kicking mom and screaming when told no, that would be a different kettle of fish. But we don't want to overreact to this. However, we do want to pay attention to the fact that kicking, right, that's a little bit over the top for a 3-year-old if it's happening on a regular basis. But we also want to, and this speaks to Augusto and Josh's point on the last slide, we want to think about the fact that mom is actually saying, hey, I'm having some trouble with this. I need some support at this time. Right? So, and Amanda just texted that. This may be age appropriate, but mom's struggle should also be addressed and supported, right? So here we have an example of, we're going to sort of land in the middle here, right? We're not going to put a 3 on this and put Roberto into the hospital. He's a 3-year-old having tantrums and doing some kicking, but we aren't going to put a 1 on it either. We're going to move in and work with mom and Roberto and take some action. Great discussion. So we're also going to spend a little bit of time on that 30-day window characteristic, because that's another one that sometimes folks can struggle with. And so when we think about that 30-day window, right, that characteristic of the communimetric tool that says use a 30-day window in considering what's relevant, okay? So what we say is rate the action level for the item for the past 30 days. Sometimes people say the highest level of need in the past 30 days, and sometimes we think about functioning over the past 30 days. But what do we mean by this? I can tell you what we don't mean, right? We do not have research that says that if a young person doesn't exhibit a need for 30 days, they're never going to have it again. We'll never see that need again. That's not what this characteristic is about. What this characteristic is about is keeping our functional focus, our assessment information fresh, and our planning of care relevant to what's happening in the life of the consumer now. Okay, so when we take that 30-day window into account, we have to use a common sense approach to it. So let's look at an example. Oops, pressing the wrong button. Okay, here's a young person named Abdo. He's 12 years old, and he's been here living in Long Island since 2004. He came to this country as a refugee from Sudan. While in Sudan, he endured significant loss and trauma. His parents were lost, and he and his brother were badly burned when security forces burned the family home down. Abdo lives with his pre-adoptive family. They describe him as quiet and sweet. He's doing really well socially in school, but he continues to struggle with coursework presented in English. So let's take a look at Abdo's story, or the little bit that we know about him from the perspective of the 30-day window. What's an historical event that clearly is something we need to keep in the back of our minds as we work with Abdo? Right, so Rachel is texting in his trauma, Melissa, Augusto, his parents' death, Monique, traumatic grief, Robin, the possibility of PTSD, loss and trauma, Karen, great catch, his emigration from Sudan, right? Cultural transitions, that's really important, right? So everybody's sort of texting in this idea that, look, this young person has a significant history of emigration and trauma, right? And folks are also texting in language, adoption, right? So in the current, now let's think about the 30-day window. We're thinking about history, that's a frame, right? We need to think about that as we move forward. Do we have evidence that Abdo is having problems associated with traumatic symptoms in the past 30-day period in this vignette? Augusto says no, no evidence, right? Excellent, everybody concurs that really, when we think about that, keeping our assessment relevant, right, there's no actionable need stemming from his trauma that we can see here. However, we are going to sort of put a 1, right, on those symptoms, because we're going to want to check in on how he's doing throughout his young life and make sure he continues to do well. But there is something functionally going on for Abdo right now in the 30-day period that we could be thinking about addressing. What is it? May not be an HCBS service, but what is it? Somebody said it already. Where is he struggling? Right, communication, people are saying, the school struggle, the language barrier. So in other words, Abdo is a child who has some functional needs, but we don't see evidence that he has needs related to his trauma. We keep that important trauma lens and that trauma focus, but we do not rate trauma as actionable in that 30-day window because we don't see evidence, right? Good, great conversation. So let's keep going. We're going to look at another example. This is Adolfo. Adolfo is 4. He's been diagnosed with adrenoleukodystrophy, which is, you all probably know this, but when I was looking at case reviews with DOH this past month, I had to look this up. It's a rare X-linked genetic disorder. It leads to neurological deterioration ultimately and a shortened lifespan. Children with this diagnosis generally die before they turn 10. When Adolfo was 2, his parents had to work with many, many specialists to find out what was causing his health issues. But now they work with a single pediatric endocrinologist, and Adolfo's doing well. His family says that this respite from the worry of losing him has been a wonderful experience. So now let's think about that 30-day window. There are two needs that are referred to in this vignette. One is complexity and intensity of treatment, and one is the life-threatening nature of Adolfo's diagnosis. One of them is historical, and one of them is current. So what would you say is the historical issue? Where do we see that beyond the 30-day window, the family had to work with a lot of systems to try and figure out what was going on medically? Right. So Rebecca's texting in complexity, Rachel, diagnosis, Rebecca, good. Okay, but what is the HCBS item that is relevant now? It's currently actionable now. Even though things are stable, what do we know is a 2 right now? Think about those items from the medical module, his lifespan, his prognosis, right? People, right? It's life-threatening. Ultimately, he'll need palliative care, even though it doesn't seem to be that he needs it right now, right? So we know now that he's stable, but we know that he will not live beyond age 10. So in the 30-day window, we continue to have that be an actionable need. But we also know that right now, he's not requiring complex care, right? Yeah, this is a sad example, Rebecca. This is actually based on it's very changed and de-identified, but based on an example from young people who our system is serving right now. Very sad. Okay. Any questions about any of those key characteristics? Or any comments? Augusto, your hand is up.
Yeah, that last palliative one, generally with palliative, they always, kind of the rule of thumb is always 6 months or less, someone who's terminal. And this is someone who, clearly based on the evidence, life expectancy is not till 10, but if we took it at that number, you're still kind of 6 years removed from thinking about that, but you really can't put that number on it because he could deteriorate in the following months, or it could be, till 10, or he could, defy all rules and live into adulthood. So this is always kind of, this is one of those cases where, what do you do, and as the nurse, you don't want to overpromise, palliative or any of that stuff. So it really kind of leaves us in a real pickle, because not only this case, but other cases where the child has some genetic issue, and right now they're stable, but we don't know when that's going to change, and there's no crystal ball method to find that out. So how do we help these people?
Right. And, I think it helps to rate the item to think about, would you be trying in some way to work with the family to develop an action plan around the shortened lifespan, regardless of how stable the kid is? Probably, right? You might have someone texted in, maybe just caregiver support, maybe just, family counseling, right? There'd be some kind of action, right? But it is very tricky. What's the right dose, right? Again, what's the right dose of services? And someone else is saying, there's no stability in the life of a child, of a family, in the family and the life of a child with a chronic life-threatening illness. So when we want to make sure and get those supports in, and we want to make sure and get those ratings correct, yeah? But if a child is fully stable, some of those items are not going to be rated as actionable. So it is going to be very tricky. Yeah, very tricky. It's great. These are a perky group. The morning group was a little quieter, so I have to say I was worried I was going to be needing a cup of coffee today, but no, we're doing well. I appreciate all this good input. So I just want to wrap this section up, and then I think we're going to take a 10-minute break so everybody can just stand up and stretch and get a drink of water. I want to wrap this section on the masking and the 30-day window and the other key characteristics with some quick tips on how to link your thinking about collaborative assessment to those items that you're going to be rating for the eligibility, right? Remember to use your HCBS items as a kind of a closet organizer. And what I mean by that is it's not a structured checklist. You don't have to rate these items as a structured checklist, right? Instead, you can have a conversation with the youth and family and ask them what are the key areas that they want to work on with HCBS services, and let those conversations drive moving toward action level ratings on the items. The list of HCBS items organizes your thinking, right? And as we've discussed, and as you've all chatted in, pushes you to want to collect information more broadly to make sure you have what you need to understand impact on functioning. But it's not meant to be a structured checklist. Learn to introduce modules and domains as conversation starters instead of using the checklist items, right? So for example, we might want to say something like, aside from the medical needs that we've been talking about, right, a lot of times children and families have challenges that are not associated with actual medicine or equipment. Is there anything like that for you? What are the hardest things about your diagnosis, your child's diagnosis, managing your child's medical care? And that's where we start to hear about complexity, parenting stress, right? We start to hear about life-threatening issues and chronicity. Use open-ended questions, right? Affirming the experiences of the people we serve. Listen a lot and use the action level language to summarize, right? I know some of you have been through my supervisor training, and we encourage you to teach families and youth who are developmentally able to do it some developmentally appropriate level of action level language. You can use that later after you use that open-ended, affirming, reflective language to say, okay, it sounds like you really want to work on clearing up the level of complexity of managing his care. You really want to get a more simplified plan of care going for him. Remember, teach others that action level language around function and action. That's going to help you move to consensus when you get to disagreement between other members of the family, consumer and caregiver, provider and family, provider and consumer. So for the rest of today's webinar, what we want to focus in on, just get this where I can see everything, okay. I want to focus in a little bit on the HCBS eligibility determination itself. Not the items so much today, but the structure and intent of it. I really think it's important that everybody have a sort of a big picture understanding in terms of the place of what we're doing in the larger systems transformation effort. So we're going to talk about the big picture, we're going to talk about the CAN structure, and then we'll actually talk about the structure of those algorithms for a little bit, okay? So first of all, let's just look at big picture. You all know that the work you do is part of a larger systems transformation for children and youth who have high levels of need, right? And that can be serious emotional disturbance, it can be a combination of medically fragile and developmental delays, and it can be kids who are medically fragile, right? But the idea behind the systems transformation is to make sure that high need children get the right dose of service. And remember, we talked earlier about that right dose being so very important, not too much and not too little. And incidentally, right, part of the dosing of services has to do with the fact that that need, the right dose, can wax and wane. Right dose can wax and wane, right? And in some ways, that's what HCBS services are all about. They're high quality services, and they're meant to target intensive treatment needs. And specifically, they're meant to make sure that specific needs that are likely to lead to restrictive placement are targeted so that kids don't wind up in higher levels of care, right? But, also in the system rests these health home serving children care managers, right? Their intention is to apply the principles of strong collaborative assessment and care management coordination to all of the high need kids in the system so that they get that right dose of baseline services to keep them developing and well and thriving. And then you all step in, right? You're sort of hanging out in the middle there. You're the evaluators who make sure that high need kids who may want those HCBS services but may have opted out of that health home level are there to get evaluated and get that doorway in if they're able to benefit, right? So the big picture, though, is that all of those different aspects of the system are existing in a sort of a theoretical partnership to make sure that kids get those services. And everybody in that system actually uses some version of the CANS New York. Now, this is the 6 to 21 version. You probably know the two age versions are somewhat different in terms of specific modules and where they lie, and some item names and item content. But the structure is very similar. And we just want you to think about this because the larger CANS really reflects that issue that we talked about earlier. We have to rate the HCBS items individually, but we want our comprehensive assessment to have a bigger picture. And so over on the left-hand side of the slide, you see those sort of turquoise hexagons. Those are the functional modules that everybody in the health home serving children care management set of programs, everybody is assessed, all youth, on those functional modules. For you, you're pulling some of that out for the kids with the SED needs. On the right-hand side of the screen are those critical extension modules. We're going to talk about the ones that you use for HCBS in depth tomorrow in webinar 2, but those are these deeper dives into high levels of need that tell us more specifically how to sort of apply the right dose of service to different needs that are interfering with functioning on the other side. So we've sort of stopped and taken a look at that big picture. Now let's take a look specifically at the algorithms, because again, we want you to think about them less as a checklist and more as a structure that makes a lot of sense from an evaluation and planning perspective, and that incidentally, when those pieces are done well, we're able to then rate those determination items and have the level of that dose of care be accurate. So first, let's think a little bit about just decision support algorithms in general. Many of you, most of you, I think, are nurses, so you know a lot of this already. What are these decision support algorithms and why do we use them? What are they for? Well, any algorithm is a problem-solving rule, right? It's a basic problem-solving rule that helps us make decisions about care consistently. Algorithms really allow the system to make not just consistent but transparent care decisions, meaning if the same problem-solving rules applied to 6 different people, right, we are able to clearly say, this is the rule we applied and these are the decisions we made based on that algorithm. It adds a level of consistency, transparency, and fairness. And these decisions are based on the current intensity of needs. Remember what we talked about, the right dose of services can wax and wane, and so we focus on that current intensity and the current complexity of needs and risks being experienced so that the services being identified and applied are appropriate to the level of need. So the HCBS level of care algorithm examines a very short focal list of needs. Incidentally, these are needs that are often strongly linked to a risk of restrictive placement because of functional issues in day-to-day living. And this algorithm that draws from those items determines eligibility for HCBS services. So, right, let's talk about the HCBS decision making support specifically. So as we said in the last slide, the items that feed into the algorithm are those that tend to link to higher levels of placement, risk, and need, right? So for kids with serious emotional disturbance, there are some key functional items, there are some key diagnoses that tend to, or behavioral health and trauma areas that tend to lead to higher risk of placement. And for the medically fragile kids, there are critical issues, including the intensity of care and things like positioning and transferring that tend to lead to more medical complications, right? So these items have been chosen intentionally in order to represent the higher levels of need for the population, right? So even though just the select items determine eligibility, we can't really understand how to rate those items, nor can we plan well for those needs unless we have an overall understanding of the functioning of the consumer, right? the more we know through your comprehensive evaluation process, the more you know, the more you make that critical link between the algorithm and the story, what's actually happening for the consumer and the family. And the more you really understand what's going on so that you can coordinate effective services, right? So because you don't complete the entire CANS New York, we just want to reemphasize the importance of this comprehensive review of current supporting documentation, as current as you can get it, and input from the child, input from the caregiver, input from all the key stakeholders in what we call that interdisciplinary team that we talked about before, that team on the baseball diamond, that all of the players in a child's life. Once you get all that information, you really are able to rate the HCBS items accurately, and you're able to have a really key understanding of how things are linked together so that you can coordinate care well. So let's take a look now at the actual structure of each algorithm and how it makes sense from an understanding and planning perspective. So this is, we're using the 6 to 21 version here, and you probably know that the 0 to 5 version is slightly different. The structure is very similar. Some of the item names and where they come from might be slightly different, but the idea is the same. First of all, you can get to eligibility through 2 different pathways, right? That's criterion 1 and criterion 2, right? If a child meets either one of those first criterion and criterion 3, then we can deem that child eligible. So let's look at criterion 1 for the medically fragile population. Criterion 1 says all you need is minimally one dangerous or disabling need related to medical challenges coming from this list of key needs. So obviously if a child is, right, we talked about this a few minutes ago, if a child is acutely ill, if risk of death is urgent or imminent, right, that's adequate to meet that criterion, right? Same with the chronicity. If the chronicity of the child's medical needs are pervasively interfering with functioning, right? If the intensity, that complex level of treatment, the invasiveness of treatment, if that is preventing and pervasive, right? If you pulled the services, for example, from a child who's highly dependent on life-sustaining equipment, right, and invasive care, if that child would die within a short amount of time, those are the kinds of places where you're going to rate that 3. Ditto on the self-care, right? Positioning and transferring can be significantly disabling needs at high levels of concern, and so you might just get 1 3 there to meet that criteria. Now, what if you're a young person who has medical needs, but no single need elevates to the level of dangerous and disabling? Well, that's where you move to criterion 2, right? This criterion is really about having 2 or more actionable needs related to medical challenges. And so we see that same series of items, right? So earlier we talked about Adolfo, right? He has a 2 on a life-threatening item already, right? But then we go down to self-care and daily living, and we look at some of the key areas that can really interfere with a child's functioning and success in home and community-based services, right? Eating, toileting, mobility, positioning, and transferring. These are things that, when actionable, can really get in the way of day-to-day functioning. And so if a child has 2 needs on criterion 2, they've sort of passed through that first door, right? So either 1 dangerous or disabling need from the list in criterion 1, or 2 actionable needs, 2 of those ratings of 2 on criterion 2. And finally, right, there's an and here. The youth has to also have, right, either a 2 or a 3 on the impairment in functioning item on the medical module, right? And so what that means is the medical challenges are actually, right, the functioning, right, is impaired at an actionable level, that's a 2, or at a dangerous or disabling level if it's very significant, and it's a 3. Now, one of the things I want to say about this is that criterion 3 is so critical, right? It's critical when we think about that right dose of care concept. The right dose of care concept is about providing HCBS services because functioning is interfered with by needs and it's likely to lead to a risk of placement. If needs are impairing functioning and we miss it because we're not taking the masking principle into account, then we might miss a child who needs the heightened HCBS services. But conversely, if a child's functioning is not impaired by the needs that are present, right, then we might over apply restrictive services. And so we want to be really, really careful about getting enough information to assess that criterion in the current day. Let's look at an example. We're going to walk through this example just in short. This is the Charles vignette that we sent you for homework for tomorrow, but we're just going to look at a subset of information from Charles's story today. And we're thinking about the structure of the algorithm, and we're also thinking about important information that we might need to know that helps us both understand the impact on functioning of Charles's medical needs and also understand some other information that we might want to incorporate into our coordination of care and our goals, okay? So Charles is 17. He's a young man diagnosed with multiple medical challenges. Now notice, folks, that you're going to see that I've actually highlighted in color some of the critical pieces of information that we're already sort of flagging for our work, both on the algorithm and on understanding where Charles is at to make sure our plan of care is a strong one. So here's Charles. He's 17. He's wheelchair dependent. Now, wheelchair dependent can mean a lot of things. So we don't know what the impairment of functioning is for Charles in a wheelchair, right? A wheelchair in and of itself doesn't necessarily dictate that there's a significant level of functional impairment. But we also see in the second half of that sentence that Charles relies completely upon caregivers for medical and daily self-care. That's where the functioning information comes in. Most notably for Charles, he understands that his underlying disease is progressive and it will result in his premature death. So there we already have some sort of a rating on life-threatening. Charles expresses anger and fear about this. Secondary to his medical diagnosis, Charles also experiences significant level of pain, especially in his legs. So here we have multiple actionable items on self-care, right? Because we know that all self-care items are going to be rated as actionable because he relies completely upon other people. We also know that he merits a rating of life-threatening on the medical module. So let's look at a little bit more information. So we've got critical information, but we don't have quite enough yet to rate what we need to, and we certainly don't have enough to build a good plan of care. So here's Charles he lives in an accessible apartment with mom and her boyfriend, and in the last 6 months, Charles's adult sister has moved back to the area and become his primary paid caregiver. Charles is deeply connected to sister and to mom and getting closer to his mom's boyfriend. Charles' father has chosen not to see Charles for 6 years, and when asked about this, Charles states, whatever. So we're getting some important information here that is not necessarily about, right, the HCBS algorithm, but what we're learning is, A, Charles's most important useful strength right now, as far as we know, is his family. They're very connected to him, and his sister is willing to sort of move forward and be his primary caregiver. We also know it's not a zero, though, because there's something there we might want to check into around Charles's father and what happened there. Now let's go back to functioning again. Charles struggles with insomnia and anxiety, causing him to often remain awake throughout the night. This creates difficulties with school attendance, participation, and performance. Charles reports that he likes school. Mom has shared that although he has friends, he has a difficult time maintaining friendships because he doesn't understand boundaries. He's often upset when friends choose to spend time with other people or don't want to do the things that he wants to do. So here we start to see important actionable needs, right? We know that he has a need on sleep and school attendance and school achievement, and we know that he has a need on peer interaction. So we can start to see, right, that we have information that bears directly on the HCBS algorithm, but there's so much more important information that's going to help us understand how much functioning is impacted and also help us understand what kind of an effective care coordination plan we can build for Charles. And it's important that we sort of dig around and get as much of that as we possibly can. So let's take a look at a younger child in the same way. This is Martine. She has been diagnosed with CP, and she also has a rare genetic syndrome that is likely to express itself with multiple delays and health concerns as she grows up. Martine's been diagnosed with failure to thrive secondary to her eating issues, and those are linked to her medical concerns. Her diagnostic picture is very complex, and her family has taken her to more than 25 diagnostic evaluation appointments in the past 18 months. And she also requires weekly OT, speech, and PT, developmentally related services, which she gets through EI. So what are folks thinking before I hit the click and put the items in? What are folks thinking that they see here that some of the HCBS items that you'd be thinking about based on what you know so far about Martine? Somebody's thinking about masking, right? So, right, what are some of the needs that might be masked right now? What are some of the needs that we suspect might be actionable based on what we see here? So we want to know what her health concerns are. That's a question. Can we have more specifics on what her health concerns are? We don't have the details. We certainly need to get more information there. What else? What else do we need to know? What else do we suspect we might want to rate and we want to get more information? Developmental delays, issues with feeding, we need to get lots more information about that. There's something in this paragraph we already can think about rating. What is it? I'll give you a hint. It's a medical module item. Mobility and complexity. I didn't even think about the mobility, but complexity of treatment, right? Intensity of treatment, okay? So, right, we have some items, right? And also chronicity. And Melissa's texting in a bunch of information. We want more functional information, she's saying. Let's get information on mobility and her developmental status. Where are the deficits? What's going on with feeding? What's going on with swallowing, and more specifics on a lifespan diagnosis. Great, so this is beautiful for all of you, right? This little bit of information triggers a lot of curiosity and also some direction when we start to think about the HCBS item. So let's get a little more information about her. Martine goes to a daycare program during the day, but her delays have prevented her from being transitioned to an age-appropriate room with her peers. She has functional challenges with expressive communication, and these challenges get in the way of her approaching the adults at daycare for help. She wears orthotics that are assistive on both legs, and now with the orthotics, she's learning to stand and walk while holding onto furniture. Martine continues to struggle with weight gain, and she's able to only eat small bites of soft food and sip liquid with a straw. Okay, so now chat in. What are you starting to see now? What are some places where you're honing in on an actionable need, and what are some places where you want more information? Failure to thrive, social needs, right? Feeding and nutrition, communication, yeah. And again, mobility, right? We know she's, right, and possibly an augmentative communication device, right? So, right, so we're really starting to hone in here on mobility, eating, right? And we know that some of her needs are definitely, the needs related to her medical challenges are definitely interfering with her functioning. So we're starting to really round out some of the information we need for the algorithm, but we don't yet have everything we want for to make sure that we have a good service set up in place for Martine. Great, it's a good conversation. So now let's shift gears a little bit and look at the algorithm for serious emotional disturbance, right? Now that algorithm's a little more complex, and I've got myself hold on here, guys. I'm not a Zoom, as Josh can tell you, I'm a little Zoom challenged, developmentally challenged. It takes me a minute to get all my little boxes where I need them to be. So the serious emotional disturbance criteria, I've left the items out because there's so many of them that it can make the structure really hard to see. But it really is that same idea, right? We have multiple pathways that can get a child through these eligibility doorways for the level of care for serious emotional disturbance. So the first criterion, 1.1, is actionable needs on select behavioral health items, right, that are strongly related to behavioral challenges, right? So the items that are selectable in criterion 1 are all from the behavioral health module, but they're not some of the items that don't generally lead us down the path of really significant challenge, right? Now you'll notice that criterion 1.2 actually also includes some behavioral health items, but it also includes trauma symptoms and risk items. So criterion 1.1 is really there to capture a youth who is having behavioral health challenges that are more sort of purely biologically psychiatric, right? So this might be a child with genetically inherited bipolar disorder or depressive disorder. 1.2 is the criterion that is meant to capture more complex presentation of serious emotional disturbance, perhaps a child with a trauma history who has attendant behavioral health issues, trauma symptoms, and risk behaviors, right? So the child can get through that first doorway through either one of those methodologies, right? One or more actionable needs, but then they have to get also through doorway 2. And so here, right, we want to think about functioning, caregiver capacity, and risk. Many of us on this call, if we were asked to fill out an anonymous survey, might say, yeah, I have one of these behavioral health symptoms. Maybe I have anxiety. Maybe I had postpartum depression when my children were born. I might be someone who is living with bipolar diagnosis. But not all of us are going to have attendant problems with our functioning or heightened risk behaviors. And the HCBS services are really there, not for kids who are simply depressed, but for kids who are depressed and who have sequela of that depression, right? Or contextual issues that get in the way of managing that depression. So that's where criterion 2 comes in. So it's 1.1, 1.2, either one of those, and you have to have some of those domains in criterion 2 rated. Okay, so we're going to look, just like we did before, at some examples. We're talking here about Tammy. So Tammy is a 7-year-old second grader. She lives with her dad, Ronnie. At school, she's inattentive and hyperactive and highly distractible. She has abruptly left her classroom multiple times and thrown tantrums and even grabbed the breasts of her father's girlfriend. There are multiple instances of verbal and physical aggression toward peers and toward siblings when she's upset. Okay, so let's think about this first piece. Let's chat into the chat box some of the items or some of the issues that we're identifying here that we might be tempted to rate, or we know we want to dig in and get more information about. What are we concerned about here? So I'm going to just holler out functional limitations, impulse control, anger, her behaviors affecting school, or is it? Her aggression, what medication is she on, right? What's the etiology of the anger? It needs to be diagnosed. Does she have any kind of an abuse history? What's the parent-child relationship like? So all of this information really leads us to have lots of questions. It also allows us to begin to rate, right, some of the items from the behavioral health module. Her attention and concentration, her impulsivity, and her anger control are already rateable at a 2. Let's get a little more information about her. She's diagnosed with bipolar disorder. Okay, so there we go. Now we understand she she sort of seems to, right now, as far as we know, kind of hang out solidly in that criterion 1.1. She swears at adults regularly. She's shown defiance toward adults, especially her teacher. And she's been stealing from a teacher and made explicit drawings of sexual anatomy. So now what are folks thinking about in terms of, so someone's asking about sexual trauma and her hypersexual behaviors, right? So we do, right? We want to know, does she have a sexual abuse history? We also want to be careful because we know that individuals with the bipolar disorder can be hypersexualized in and of themselves, right? But yeah, we want to see, what has this child been exposed to, right, that is putting that sexual content in there. So we also know, though, that we can slip over to 1.2 and we can start rating her danger to others, her impulsivity, and her attention and concentration, right? So let's get a little more information about what you've all been asking about in the chat, which is what's going on at home. So Tammy's father, Ronnie, was recently arrested for driving while intoxicated with Tammy and her siblings in the car. Tammy has difficulty regulating her emotions in most settings, and she doesn't show an age-appropriate understanding of how her actions can impact others. Many of her behaviors occur while she's in school, but she also misses 1 or 2 days of school a week. And so folks are already chatting in, right? Great. Substance use in the home, poor caregiver decision-making, what's the level of supervision ongoing in the home? So we start to think about that third set of criteria, right? There are some functional areas we want to start looking at in terms of the caregiver capacity and the child's functioning to begin to round out criterion 2. We can certainly rate a 3 on caregiver decision-making for driving with your children in the car while you're drunk. That's a dangerous level of decision-making issues, right? We can also give Tammy decision-making and judgment because we know, right, that she has grabbed the breasts of another person. We can also give her certainly a rating of school behaviors, and we now can give her a rating on school attendance because she's missing 1 or 2 days of school a week, right? Sexual aggression is also now rated as a 3. And someone else is saying, Augusto is saying, right, that we actually have to start thinking about trauma now because watching dad get arrested could have been a trauma in itself. And then Rebecca's asking, where is mom, right? Where's mom in all of this? We want to find out more. So this is right. We sort of start to have information to rate the algorithm, but we're also finding we have so many more questions. And that's where we want to make sure that we do that thorough assessment, make sure our algorithm ratings are correct, but make sure we really understand how a child's needs are impacting functioning and what kind of a plan of care can be put together. So we're getting close to wrapping up here, and I just want to check in before we go on to next steps with anybody have any questions or comments or examples that you want to throw out before we end today. Coming back to the, you can see some of your faces and some of your, I call them supermodel photos when people put these really beautiful photos of themselves up on their Zoom. So great, Katina, you're talking about how diagnoses such as autism and other developmental delay issues also fall into SED. Well, right, so technically, right, these two processes are not meant to assess or identify what we would call a pure developmental delay population, right? So the HCBS algorithms as defined are meant to identify children with Med-Frag-GD combination, Med-Frag, and also serious emotional disturbance. Sometimes, though, functional needs can be similar in the developmentally delayed population or children with autism, right? So sometimes those functional needs overlap. So what we want to see, right, is does the child fall into eligibility based on these two sets of criterion that we've talked about today? If the child doesn't, and we feel there's a high level of need, that's when we sort of work with the DOH folks to identify what the correct pathways are to get them where they need to go. Because we do, right? It's not so black and white. We do see a crossover of functional needs between and among these populations. Augusto, you've got your hand up. Did you want to say something or ask or?
Well, I actually was going to say something else, but Katina brought up such a good point about the autistic children because, you know, I go back to my inpatient psych days and getting autistic children on the unit, and it was terrible because so many of these children really weren't appropriate for a psychiatric setting, but they had behavioral problems. Okay, and then now in this program, you have autistic children that don't really have medical needs. So it's really challenging for us to help these families.
Right, and it's funny, Augusto, you and I know each other from, I think, from way back, right? We met, I think, I want to say years ago we met when we were both working with in inpatient settings. And what we know is that behavior issues, functionally behavioral issues for a child with autism, the etiology and the remediation can look very different, right, than kids who are coming in with purely psychiatric or trauma-related behavioral issues. And so what we're trying to get at, right, is trying to sort that out and make sure kids are getting services that apply to their needs, right? But sometimes they can look very similar, so we have to try and parse that out. What was the other thing that you were going to say?
I was just earlier about when we were talking about keeping certain things in context, because I had thought of a specific case about a teenage girl who she had been hospitalized about 3 years before. You know, so clearly that's something that wouldn't apply to that 30-day window. However, it was significant because she was hospitalized for 2 years.
Oh.
So that, you know, that of course is something that it has to be kept in context because, you know, being 2 years in a long-term facility is just, wow, you know. So yeah, that was the other thing I was thinking of.
Right, and I think because, right, so that kind of a piece of information is so critical, and it makes us start thinking about some of the functional issues we want to carefully assess, because we know that the impact of long-term institutionalization is that it can eliminate our community ties, it can reduce social skills and coping mechanisms, it can interfere with attachment and family relationships and the success of the living situation, right? So although we can't rate it as current, that powerful piece of information makes our wheels start turning about possible questions around current functioning. Josh, do you want to add anything to that one?
You know, the only piece I think I would say around that is, you know, one of the ways that I kind of teach this concept too is to say certainly our assessments are relevant to the last 30 days, but history, like the history you mentioned for that young person, Augusto, that history, while it might have happened 2 years ago, was probably present in some way in the last 30 days for that child, right? And so we want to recognize sort of how present and how impactful it was on that child's functioning this month and this past month, right? Because some kids may really have the resilience to kind of overcome something like that and have it be a memory, but only sort of a memory now. And other kids may not have had that resilience, and the trauma from that experience has carried through right into their behaviors and their functioning today, right? And so it would be very, very relevant to that child's functioning right now today. So that's a really great example. It's probably one I'm going to steal from you and use in future trainings because I like the way that represents, you know, this concept.
And it also points out, right, that the quality of both contexts is important to find out about. What kind of an institutional placement was it, right? And we all know some of them are great, some of them are mediocre, some of them are terribly toxic. And then what's the current life situation, the living situation for the child, and how much capacity has that living situation had to reintegrate the child, and how much support. And those then become current functioning questions that HCBS services would be very relevant to. One of the best uses of HCBS services are to pull kids out of restricted placement and make that transition successful. So we have another question: where does autistic spectrum disorder belong? It's not on the LPHA as an SED diagnosis, but many autistic children do not have significant medical issues. So I want to check in and see if Colette had to step off, but Colette, are you back on the call? That might be a good question for you to answer if you're here. I'm just going to scroll through. She had another call she had to step on too. No, she's not back.
Not seeing her, but we might want to parking lot that question for Wednesday and get her response.
Yeah, I can very quickly say that the two algorithms associated with the CANs do not incorporate the DD population because there's a separate eligibility pathway for the DD population, and the DOH team can speak to that more effectively. Then we have another question coming in.
Hi, I'm Susie.
Yeah.
I think I'm reverberating here.
Do you have a phone and a computer on?
I can't hear me?
Yes.
Oh, okay.
Katina?
Yeah, I think if that is something we can go over tomorrow in terms of autism, because what we're finding is, you know, we're doing MedFrag SED. The autism fits more into DD, but the problem is sometimes when we are talking to providers, that gray area is very difficult for them. Sometimes the child really presents with a lot of behavioral, you know, issues, but they're not quite seeing that as being MedFrag appropriate. So I just, you know, I think if that's something we can explore more tomorrow, I'd appreciate it.
Yeah, Katina, if it's okay with you, tomorrow we have sort of set content, but Wednesday's that place where we can work in some of this evolving content, and we can ask the DOH team to speak a little bit to that. So be sure to be on one of those two webinar 3s, and we'll definitely address that there, okay? I want to back up though, because when we were talking about the history of residential placement, we had a question, and I want to back up and answer that question. Rebecca has asked about, can we rate it higher? If folks can mute themselves, that would be helpful, thanks. So can we rate?
You have not entered any number. Please re-enter your meeting ID followed by pound.
So somebody's phone is making a lot of noise. Just mute yourself.
It's Katina. Katina, we can hear you dialing.
Trying to get back in. So I think, Rebecca, you're asking.
Your participant ID followed by pound. Otherwise.
I'm going to, oh, thank you. Thank you, Josh. Okay. So Rebecca asked a question. Rebecca, I think you were talking about when Augusto and I were talking about someone in 2 years of residential care. So your question was, can we rate it higher even though it was more than 30 days ago, but it's still very relevant? So what we're trying to say is it's a little bit of both. We cannot actually rate the 2 years in an inpatient setting higher in the current 30 days. But that information becomes a critical lens through which you're going to look at functioning in the current 30 days and really know, or go to your supervisors. Augusto's very seasoned with kids in behavioral health, and say, what are some of the things I should be thinking about? What are the long-term impacts of institutionalization on functioning, right? What are some of the things I should be assessing for in terms of functioning in the current moment? Those things would be the things you would rate within the 30-day window. They would be relevant. Does that make sense? I'll be right back to you, Augusto. I've got some other questions I want to just tend to. Melissa said that she's found that when asking about some behaviors, parents comment or the children comment that behaviors occurred 2 months ago, to the point of involvement with police or school sanction, but it hasn't occurred in the last 30 days. The child says they would have done the behavior if they were not being forced to comply by punishment. How would you rate those? Well, I'd like it to be a little more specific, but I would circle around it and I would want to know this. How old is the child, first of all, right? So I have 13-year-old twins, and one of my 13-year-old twins says no to me every time I ask him to do something, but he does it anyway, most of the time, right?
These are typically teenagers.
Right. And so it might be typical for a child to say, yeah, I would do it anyway if you all weren't forcing me not to do it, right? So I want to know, is that statement a developmentally appropriate statement, but whatever interventions are in place have really resolved or are improving the behavior? Or let's go back to the masking principle, yeah? And let's ask ourselves, whatever's in place, is it skill building and response, or is it control masking the behavior? And then
it's control masking the behavior, and often that's what I find. And so I am struggling in those situations, feeling like the underlying issue that's causing the behavior has not been resolved or not been dealt with. So therefore, that behavior is going to occur again once this sanction has been removed.
So when you're talking about sanction, you're talking about like a court sanction?
Yeah, either a PINS petition, or the child is on a probation, or the child is expelled from school for throwing a desk, or for hitting a teacher, swearing, whatever the actual behavior is, the child is now being punished for that. However, once that punishment has been removed, that child's going to continue that behavior when he becomes angry again, because the issue was never resolved in the first place.
Right. Yeah, so you're describing something that is the exact reason why this masking principle is so important, right? And that is this understanding that things like zero tolerance policies and punishments actually don't get at the etiology of most behaviors, right? And so when we put those in place, sometimes behaviors stop, but they often recur. So I would definitely rate that with the masking principle. Josh, would you add to that?
I would only add, Susie shared that that nice kind of workflow that we have around the masking principle, which is available on a nice PDF tip sheet, and I would encourage you to download that from our website. We also have a similar PDF tip sheet on that 30-day principle, and it also has a little kind of walkthrough flow chart with similar kind of questions, right, around the idea of thinking about some of those behaviors that might have existed 2 months ago, and thinking about the likelihood of their return given certain circumstances. And so I think that can be really helpful to you folks as well. So I would definitely encourage you, kansnyinstitute.org. I'll put it in the chat one more time for you. But those tip sheets I think can be helpful.
Good. Really, this is great discussion and great questions. Augusto, you have had your hand up for a while. Talk to me.
Yeah, no, it was just actually to continue the follow up with Rebecca and that child. It just made me think of because before this I worked on an ACT team, and some of the training that we went, some of the team members were peers, people that were previously involved. And one of the common things that they all shared was that good institution, bad institution, and all of them in between, what was the most striking was, what was the most traumatic was actually being institutionalized. Okay, that idea that your freedoms were being taken away. No matter how well or poorly it was done, it definitely left an impact, and it was something that a lot of those peers, even to this day, are still kind of working through. So, that was, not to understate how significant it is, when someone is hospitalized, especially for an extended period of time. But even if they were just in an acute facility,
Yeah.
that this is something, like what they say, the gift that keeps on giving, but kind of in a bad way. Yeah, but
Yeah, right. I mean, it's like pervasively what we're learning is that you cannot pull people out of their interconnectedness to their neighborhood and their family and their friends and their world and expect it to go well, right? It's really well said. And I think before we move on to wrap up, that brings home what Augusto is saying, the critical nature of this piece of the transformation that you are all doing. The work that you're doing, which I know can be challenging and maddening, doing it in the way that you have to do it, right, is so critical because you're making sure that folks who don't necessarily trust or want to opt into one piece of the system get access to some of those services that prevent these kinds of disruptions, right? Institutionalization, hospitalization, right? So it really does just wrap us around at the end of the webinar today to the importance of your work.